All right, good afternoon. My name is Rob Azeltine. I chair the New England CEPAC, and today's meeting is Supervised Injection Facilities and Other Supervised Consumption Sites, Effectiveness and Value. Before we ask the CEPAC panelists to introduce themselves, I want to remind everyone that we ensure here that all speakers and participants have met the financial conflicts of interest and disclose their financial conflicts of interest before participating in the meeting and have conformed to the ICER conflict of interest policy. So I'm going to call on the CEPAC members to introduce themselves, to say what it is that they do, and then to confirm that they do not have any conflicts of interest. Al Whitaker.
Good afternoon, everyone. My name is Al Whitaker, and I am actually a pastor here in the city of Boston, as well as I do work around health equity and social determinants of health for the state of Rhode Island.
Thank you. Kelly Buckland. Kelly, are you on mute?
Sorry, I was on mute. I'm sorry, and my cat is like really wanting attention right now. Sorry. Hi, I'm Kelly Buckland. I'm the Executive Director of the National Council on Independent Living, or we go by NICL, and we are a membership organization for the Centers for Independent Living and statewide independent living councils across the country.
Thank you. Jason Wasfy.
You're wonderful. Thank you.
I'll tell Kelly to help you.
Sorry, I'm probably the mute. My name is Dr. Jason Wasp. I'm a cardiologist at Mass General Hospital. I'm an assistant. I'm a medical director of a physicians organization here, and I run a program and research health outcomes for cardiology. Nice to see you all.
Thank you. Jason Schwartz.
Good afternoon, everyone. My name is Jason Schwartz. I'm an assistant professor in the Department of Health Policy at the Yale School of Public Health. It's good to see you all as well.
Claudia Gruss.
Hi, I'm Dr. Claudia Gruss, and I'm a gastroenterologist and clinical educator with New Vance Health, and I have no new conflicts of interest.
Thank you, Claudia. Tara Lavelle.
Everyone, I'm Tara Lavelle. I'm assistant professor at Tufts Medical Center in Boston. Do work on cost effectiveness and patient preference assessment. Yeah, nice to see everyone. I don't have any conflicts of interest.
Thank you. Greg Lowe.
Hi, I'm Greg Lowe. I'm a pharmacist and pharmacoepidemiologist who runs the Mass General Physician Organization's ambulatory pharmacy program, and no new conflicts to disclose.
Rena Conti.
Good afternoon, everyone. My name is Rena Conti. I am an associate professor at Questrom School of Business in Boston University and the associate director of pharmaceutical economics and policy for the Institute for Healthcare Innovation and Change. Thank you.
Oh. Thanks, Mark. Go ahead. I think Rena was saying she
no additional conflicts of interest. Sorry about that.
That's okay. Martha Gold.
Good morning, good afternoon. I'm Martha Gold at the New York Academy of Medicine, where I'm a senior scholar. I'm a family doctor and a public health professional, and I don't have any conflicts of interest. Thank you.
Thank you. Megan Golden.
Hi, I'm Megan Golden, co-founder and co-director of Mission Cure, a nonprofit patient advocacy organization for people suffering from pancreatitis, and I have no additional conflicts.
Thank you. Brian O'Sullivan.
Hi, I'm Brian O'Sullivan. I'm a pediatric pulmonologist and professor of pediatrics at the Geisel School of Medicine at Dartmouth College, and I have no further conflicts of interest.
Stephen Kogut.
Good afternoon, everybody. I'm a professor at the University of Rhode Island College of Pharmacy, where I teach and conduct health outcomes research. I've also worked clinically for about 15 years as a pharmacist at a psychiatric and substance use hospital in Providence. and I don't have any conflicts to update at this time.
Thank you. Eleftherios.
Hi, everyone. This is Lefteris Milonakis. I'm a professor of infectious diseases and professor of molecular microbiology and immunology at Brown University. I'm also the director of the infectious disease division here. Nice to be here, and I have no conflicts of interest. Thank you.
Kim Lenz.
Hi, good afternoon, everyone. My name is Kim Lenz. I am the Director of Clinical and Operational Pharmacy for the Massachusetts Medicaid program, Mass Health. I'm also Assistant Professor in Family Medicine and Community Health at the University of Massachusetts Medical School, and I have no conflicts of interest.
Thank you. And Ed Westrick.
Hi, I'm Ed Westrick. I'm a primary care doc with Oak Street Health in Rhode Island. No conflicts of interest, but certainly a bias. I used to have a small substance abuse practice when I worked in a health center, and I can't help but think of some patients who might be alive today if these services were available to them.
Thank you, Ed. And again, I'm Rob Azeltine, professor and chair of the Division of Behavioral Science and Community Health at UConn Health and director of the Center for Population Health there. And I have no additional conflicts to report. We'll now turn to call on our community and clinical experts to introduce themselves and again to declare any potential conflicts of interest. So first, Matthew Bond.
Hi everyone, my name is Matthew Bond. I'm the program coordinator with the Canadian Association of People Who Use Drugs. I'm also a national board member with the Canadian Students for Sensible Drug Policy and a knowledge specialist for the Dr. Peter Center, which is in Vancouver. I don't know if any of you have heard of it, but it's quite the innovative healthcare facility. And I guess I am someone who actively uses drugs, so I also have a strong bias. My drug choice is fentanyl. And for conflicts of interest, I have received funding from Gilead and AbbVie not pertaining to this or anything related to this.
Thank you, Matt. Peter Leslie. Peter, are you on mute?
Sorry about that.
No problem.
I work here in Toronto. I work on the front lines of harm reduction here. I also do a lot of, so I work at an SIS here in Toronto. And I helped establish Moss Park back in 2017, the first renegade or unauthorized Moss Park, and then helped establish the indoor funded space, which was the first SIS here in Ontario. I do a lot of work around overdose prevention. I'm a former EMS paramedic, formerly homeless, former injection drug user, but I still do use drugs myself, but no longer homeless or injecting primarily. So I work on the front lines, and I've done a lot of work setting these places up. So there you go.
Thank you, Peter. And any conflicts of interest to report?
Oh, of course not. I've had some contact with Gilead as well, but it was with a Hep C program. Yes, yeah. But
okay,
yeah.
Thank you, Scott Hadling.
Hi everyone, I'm Scott Hadland. I'm an assistant professor of pediatrics at Boston University. I'm actually from Vancouver, Matthew. It's nice to meet you. I grew up there and moved away in about the year 2000, so I'm a little out of touch with British Columbia, but my family's all still back there, and I visit often. And over the years have conducted clinical work, actually in association with the folks that set up Insight in Vancouver. And my own clinical practice here in Boston is that I take care of adolescents and young adults who use substances, and we run a program for them. And actually also lived for 8 years in the Mass and Cass neighborhood of Boston, which is sort of the center of our drug use market.
I just want to say, everybody thinks I live in Vancouver. I don't know why, but I live on the East Coast. So I'm in Nova Scotia, but you know, I still lose 3 or 4 close friends every year, and I'm not in the downtown East Side.
Thank you. And Scott, any conflicts of interest to report?
No conflicts of interest, thanks.
Thank you. And finally, Alexis Roth. Alexis, are you on mute? We may have a technical difficulty. We'll return to Alexis at a later point. So finally, I just want to repeat that we're going to request that other speakers and any of our policy roundtable participants and any individuals making public comments should disclose any financial relationships with industry or any other potential conflicts. And we will be presenting this information publicly on the slides. Now I'd like to introduce you to Dr. Stephen Pearson. But before I introduce you to Stephen, I think Alexis is with us.
Hi, yeah, sorry about that. I was here earlier, but had no audio controls, but I seem to have been rogue enough to defeat the Zoom. So I'm Alexis Roth, and I am an associate professor in community health and prevention at Drexel University in Philadelphia. My work has concentrated on the intersection of gender and drug use as determinants of women's sexual health, integrative and novel ways to look at co-locating health services within existing structures that folks who use drugs utilize in order to increase access to healthcare, as well as strategies to reduce opioid-related overdoses. I am co-PI on a grant from Arnold Ventures to evaluate Philadelphia's Safe House when it opens. And other than that, I have no conflicts to disclose.
Thank you very much, Alexis. So now it's my pleasure to introduce you to Dr. Steve Pearson, President of ICER.
Thank you, Rob, and thanks to everybody who's already been introduced and to those participating by watching online. Let's dive right in. Why are we here today? Let me just cite a few quotes that we received from folks. Here's one that says, "Lots of people are dead because they overdosed in public, alone with no help around them. I can think of 13 people who are still alive today because I was there to call 911 or to seek help." This from a client of a supervised consumption site. Someone else said, "People who use drugs don't have a lot of places they can go without being stigmatized. So it's so important to have a place you can go and be welcomed and used safely." This from a staff member and a client at an overdose prevention site. So these give you some of the sense of why we're here today. It's, you know, from the people who are using these services and who recognize the need. Why we're here today really is partly because the national opioid crisis continues despite, you know, COVID-19, despite everything else. I found one recent statistic that said between April 2019 and April 2020, 76,000 people in the United States died of an opioid overdose. And that's the highest total for any 12-month period ever. So we are still really wrestling with this, despite the fact that we are wrestling with so many other things in our healthcare system today. And in that context, society really is challenged to try to figure out how we make the best use of our resources to help people. There are lots of different options, lots of different things are talked about. There's always going to be some limitations on the resources that are available. So it's helpful to think about the evidence and the opportunities, but to realize that ultimately we're trying to address the needs of the person and their family, that we can see who's in front of us. But throughout society, there are going to be other individuals, other families, we also have to try to keep in view, and they come in many different colors and shapes and sizes and forms, but ultimately we have to come up with an approach to the opioid crisis that keeps everybody in mind as we try again to focus on the folks that are in some sense perhaps the tip of the iceberg, but are always part of a larger community. So you've heard about the CEPAC, the members of the New England Comparative Effectiveness Public Advisory Council. ICER convenes CEPAC and provides, if you will, the academic secretariat, the work behind the reports. So just briefly about ICER itself, our sources of funding in 2020 is kept updated on our website. And you can see here that from our total revenue, about 70% comes from nonprofit foundations, not associated directly with the health kind of industries of payers or life science companies. The chief funder, the largest in that set, is the Laura and John Arnold Foundation, but we have grants from several other foundations as well. And we do take direct contributions from both life science companies, manufacturers, and from health plans and provider groups, but that money is used separately for an evidence policy program to convene leaders of those organizations and is not used to support the research and the assessments that we do, for instance, for this meeting. So the report that's kind of the backdrop for this meeting was developed over about a 8 month period. And it starts with what we call scoping, which means really trying to understand what are the key questions, what do we not know ourselves about the key questions that need to be addressed. And we reach out and get guidance from, in some cases, the patient community. In this case, it would be people who use drugs, but also from harm reduction organizations, from current and former staff members of supervised injection facilities and SSPs, and researchers, clinical experts. All these folks were part of our scoping at the beginning. And they serve a very important purpose to really, again, orient the overall approach to try to make sure that the research we do on the evidence is meeting the needs of the decision-making community. So we do go off and our staff do an analysis of the existing evidence wherever we can find it. We also do a cost-effectiveness approach to thinking about the long-term value, and we work often with outside academic collaborators. In this case, they were at the University of Washington. The report goes through several cycles of public comment and revision, and we were particularly grateful to have as expert reviewers for this report, Brandon Marshall, Amos Irwin, and Matthew Bond, who's with us today, and you can see their affiliations here. Now, in the report, I just want to talk briefly about how the evidence is structured to support the discussion and the votes around the policy options that we have. And again, we always start with this general idea that in the health system, and today we're going to be talking about things outside the health system as well, but we want fair pricing that will be linked to the ability to provide fair access for all patients and the wherewithal for future innovation. And the report talks, therefore, about two aspects of evidence that can support that goal. And one part of it is long-term value for money, and the other is short-term affordability. We've already heard several folks here who were involved in dealing with hepatitis C treatments. Sometimes that long-term value for money is there, and then it's hard to figure out what the short-term affordability aspects are. So sometimes those are in conflict, but not always. Now, long-term value for money itself is kind of a complex composite idea. And we like to think of it being broken down into about five different categories. One is we want to see if interventions can lengthen life. That's obviously one of the core goals of creating better health. Sometimes treatments do that, sometimes they don't. Sometimes interventions do that, sometimes they don't. They may also, however, help us return to better function, or do so with fewer side effects or other adverse effects than other options. When we look about the cost, when we talk about the cost here, we want to be really clear that we're talking about the overall costs, including potential cost offsets, and we will definitely hear about that in this situation. Cost offsets inside the healthcare system from better health, and maybe cost offsets outside the health system that come from better health and better functioning. We also have things that we call benefits beyond health. These can be things, again, that are things that are recognized as important to patients or to the community, that we're talking about. And it could be for their families or for their ability to return to work, that kind of thing. And in addition, kind of enveloping all of this in some way, is the idea that we may, as a society, have special goals, special priorities, problems that we need to address, and that may be something that we need to talk about specifically. So the agenda today to discuss those aspects of value and then to break into a broader discussion around the policy ramifications. I'm not going to go through each element of this, but we'll start here, go through a presentation of the clinical evidence in the report and the economic evidence. Then we're going to have public comments and discussion provided, and then the CEPAC will deliberate and take a number of votes on the effectiveness and the value of the interventions we'll be talking about. And then we have a kind of a nice full hour and 40 minutes to have a policy roundtable where we'll really be focusing on how do we translate what we know so far? What can the evidence tell us? What can't it tell us? But how do we translate that into what we should be doing today and in the future with the best way to bring services online and implement them in a way that will help patients and the broader community. We'll have reflections from the roundtable and then also finally from the New England CEPAC members themselves towards the end, and we'll be adjourning at 5 o'clock. So with that, let me go ahead and hand it over to, oh, I'm sorry, we already met our representatives from the community of people who use drugs and the clinical experts. So thank you again to them. They serve a really important resource and they will also be part of that policy roundtable along with others. But throughout the morning they're here certainly as a resource to the CEPAC as they hear about the evidence and may need to get perspective on it or opinions from these folks. So thank you again for your participation. And with that, I can turn it over to Eric Armbrecht, who is professor at St. Louis University, and Eric will be taking us through an overview of the clinical effectiveness information in the report. Eric?
Great, thank you, Steve, I appreciate it. And greetings from St. Louis, Missouri and St. Louis University. It's my honor to present the work of our research team today. And I'm grateful to Dr. Pandy, Ms. Fazioli, Ms. Heron-Smith, Dr. Borelli, for the collaborative spirit, the commitment to the ICER mission, and their remarkable thoroughness. It was the best team ever. And I must recognize ICER Medical Director, Dr. David Wren, for his mentorship and contributions throughout this project. All of us are here today to answer questions from the CEPAC and others and support your deliberations. Keep in mind that my presentation will only feature highlights from this 130-page report. So let's begin. ICER selected this topic in response to the opioid overdose epidemic, which is devastating communities across America, where overdoses are now the leading cause of injury-related death. Of the 67,000 drug overdose deaths that occurred in 2018, about 70% involved opioids. And as the graph illustrates, the recent increase in overdose deaths has been driven by heroin and other synthetic opioids, such as fentanyl. The epidemic is everywhere, with society's most marginalized people at the greatest risk of death. This map shows rates of heroin use. Some of the highest rates of overdose deaths are in New England, where many of today's CEPAC members live and work. Next slide. Let's recognize that a supervised injection facility, or a SIF as we'll call it today, is among many strategies in a harm reduction portfolio, including using select opioid medications to block cravings for heroin and stop destructive behaviors, providing clean equipment for safer injections, distributing naloxone so broadly that the antidote is readily available wherever and whenever it's needed, and checking drugs for toxic ingredients. But today we'll focus on the last one, supervised injection facilities. Next slide. So what is a SIF? Well, a supervised injection facility is a legally sanctioned place, permanent or mobile, where people can inject drugs that they have obtained elsewhere. If they permit clients to smoke or snort drugs, a supervised consumption site is the more appropriate term. Next slide. While the SIF model implementation can vary based on community needs, resources, funding, there are three core features that we should recognize. Number one, sterile equipment. Number two, trained personnel for supervision. And number three, first responder medical care. The sites may also offer other services such as health screening, treatment for substance use disorders, referral coordination, or healthcare and mental health services. There are no legally sanctioned SIFs that operate in the United States, but plans are in the works from Boston, Burlington, and Somerville, Massachusetts to San Francisco and Seattle and many points in between. For the purposes of this review, we're considering the incremental benefits of a SIF in comparison to a syringe service program. On the next slide, the table, if you can go, yeah, the table compares the services available for both, right? For example, a SIF observes injections and offers first responder care, but by contrast, an SSP does not. Both offer clean, sterile equipment to clients. Ultimately, this review seeks to answer the question, what is the net health benefit of implementing a SIF when layered on top of SSP services? This comparative approach is taken because we believe largely communities willing to implement an SSP are the only ones that would consider a SIF. So the SIF is, quote, an additional harm reduction strategy. Next slide. The research team identified 48 peer-reviewed studies of SIFs that met the inclusion criteria. And you'll notice that practically all come from Canada and Australia. Most evidence comes from one SIF in Vancouver, and no data is from the United States. I want to point out how we handled SSPs, right? We focused on outcomes reported in systematic reviews in hopes that we could benchmark whenever possible. In the end, the comparison was limited to the domain of infection prevention. And this makes sense, right? SSPs were established to address HIV and hepatitis. To be clear, we found no published studies that made a head-to-head comparison of SIFs to SSPs. Next slide. So let's start. Here is our summary of the evidence for you across 5 areas of outcomes. Number 1, mortality. We have confidence that SIFs impact overdose mortality. First and foremost, we know of no reports of an overdose death at a SIF. Evidence regarding community-level mortality comes from Vancouver, as reported by Marshall et al. And next slide. So here is where Insight Vancouver is located, in this neighborhood, in the downtown East Side neighborhood, just down the street on the right-hand side. SIFs serve a particularly small geographic area, measured in blocks and not miles. Most clients will travel only short distances to access a SIF, and so the impact is likely concentrated geographically. Next slide. Marshall et al. Calculated change in overdose mortality before and after Insight's opening in 2003. There was a 35% reduction in the neighborhood, that's a 500-meter radius around the SIF, versus a 9.3 reduction elsewhere in the city. The pre-post design and focus on small geographic areas supports our confidence rating of moderate, that SIFs do reduce overdose mortality in the community. In the nearby community, you see location matters. Next slide. Oh, okay. The next outcome I'll talk about is emergency services. We concluded that SIFs reduce use of emergency response services. For example, Salmon et al. Calculated incremental 20% reduction in ambulance rides for overdose use after a SIF opened. How? Well, overdoses within a SIF are handled with appropriate first responder care, which prevents a 911 call. Our confidence in this evidence is moderate, and we acknowledge that SIF operating protocols influence this outcome. That is to say, a SIF has policies to decide when they engage ambulance services. Next is infection prevention. So a SIF improves injection risk behaviors, which is a proxy for HIV and hepatitis infection, but is not that exactly. And it does so better than a SSP, but we don't have a direct comparison. A pooled estimate of 3 studies suggests SIFs are associated with a 69% reduction in syringe sharing. A meta-analysis of 6 studies estimates a 48% reduction for SSPs. We have moderate confidence that SIFs are equivalent or better than SSPs in improving injection risk behaviors, and by extension, infections. On the next slide, we looked for data. We look for data, right, about community and environmental outcomes. We have moderate confidence that SIFs reduce public drug use, such as seeing people taking drugs in a park. Our confidence in evidence is lower for SIFs' ability to reduce litter and trash, and the impact on crime is uncertain, neither favorable nor unfavorable. We are fortunate today to have many experts with us today to discuss this topic during the policy roundtable. I'm sure it will come up. On the next slide, I want to point out that stakeholders told us SIFs were an important access point to social, medical, mental health services. Many cited how well a SIF builds trust-based relationships via frequent interactions with clients over time. And that's much different than an SSP's transactional and periodic interactions with clients. So while this makes perfect sense, our team has low confidence in evidence related to this outcome for two reasons. One, because results are based on a comparison of high versus low SIF use. And two, stakeholders pointed out that referral coordination only works if there are low barrier, culturally competent service providers available to accept the referral. SIFs do not magically expand a community's capacity for needed services such as medication-assisted treatment. We hosted 48 interviews, or we hosted interviews with 48 stakeholders, including 11 clients, to scope out this project, explore evidence, and capture the client perspective. I'd like to share 4 of the many themes that emerged in that work. The full report includes more, but here's what we heard. First, SIFs offer camaraderie and community. And because SIFs are a place that people feel safe and welcome, they come. Trust-based relationships are built, enabling support and assistance to follow. Second, clients describe the bias and prejudice of hospitals and doctors and the stigmatization people who use drugs experience when seeking healthcare. SIFs are different and meet people where they are and who they are, offering care and support without judgment. Third, there are underlying social problems associated with opioid use disorder, namely housing security. Stakeholders expressed the need for substantial changes in social policies to reduce homelessness, which would in turn help tackle the opioid crisis. Fourth, providing on-site access to social workers and counselors was widely considered essential. Integrated services facilitate acceptance of social, medical, and mental health services. As one stakeholder said, a simple consumption room is better than nothing at all, but having a little bit of social support on site is fantastic. So there are many controversies surrounding SIFs, including challenges to their legality in the United States. On this slide, controversies and uncertainties pertain to those that impact estimates of effectiveness, and therefore are conclusions regarding evidence for or against SIFs. The studies about SIFs are observational, generally with a pre-post design or a prospective cohort. There are no trials, no clinical trials with control groups. There are concerns about how the findings from studies of SIFs in Vancouver and a few other places too can be generalized. Local contextual factors matter in public health interventions. Data from key studies was collected 10 to 18 years ago. Since then, the world's injected drug supply has become more lethal, fentanyl, for example. The value of a SIF is associated with the overdose risk of the drugs injected. So if the risk is substantially greater today, the incremental benefit of a SIF may be greater too. Third, the next one is frequency of SIF use, right? It's unknown how often a client needs to visit a SIF for the benefits to actualize. Is there a dose response curve of sorts? It's unknown. The ability of a SIF to reach clients, cultivate support from the broader community, and deliver results depends on its level of collaboration with the police. This is difficult to measure, and policing is related to the degree to which drug use is criminalized in a local community. I would like to call your attention to 2 implementation concerns. Right? First, the honeypot effect, or attracting more drug activity to a neighborhood. We found no credible evidence in support of this so-called honeypot effect. But this fear or concern is part of the discussion surrounding SIFs. Second, employee health and safety. Employee manage operations, check-in, supply replenishment, cleaning, overdose response, and much more. SIFs must be attentive to the safety and well-being of staff as well as their clients as they begin to implement. Next slide. Thanks. Later today, this CEPAC will vote on other benefits and contextual considerations, and I look forward to that discussion. As you prepare for the vote regarding historically disadvantaged or underserved populations, I invite you to consider how SIFs serve marginalized people who have lower life expectancy and higher disability. Clients have housing insecurity, mental illness, childhood trauma, unemployment. It seems all the social determinants of health are in play. One client described SIFs as serving, quote, the poor, homeless, marginalized, the beat down people. He explained that he'd, quote, given up on himself until he found harm reduction services. Next slide. So we responded to many public comments in response to the draft report. I appreciate all the folks that out there that provided that commentary. Let me point out a few that may find their way into today's discussions. One comment pointed out how law enforcement practices and policies can impact SIF effectiveness. I mentioned this issue earlier already. Another recommended addressing stimulant-involved overdose mortality. And we acknowledge stimulant use, such as methamphetamine, is on the rise, but we kept the project scope focused on opioids, right, in part because that's where the evidence is. And one person noted how COVID-19 is contributing to higher overdose deaths via mental illness and social isolation. Next slide. So after thorough analysis and many discussions, our team arrived at an evidence rating of B+. Why? Well, we have high certainty of the benefit related to mortality reduction, especially within a SIF, and moderate certainty for other outcomes. We did not see sufficient evidence of negative or unfavorable results to lower the rating below a B+. So here's the quick recap, right? A supervised injection facility serves vulnerable and marginalized people. It prevents overdose death. It improves injection risk behaviors, reduces the visibility of drug use, has no apparent impact on crime, and assists clients with accessing medical, mental health, and social support services, including the use of addiction treatment services. Well, that's all. Thank you very much for listening. Our team welcomes your questions and comments. Thanks.
Thank you very much. Jason, go ahead.
I just wanted to thank Dr. Armbrecht and the whole ICER research team for, as usual, just an exceptionally well-researched report. And a lot of the things you pointed out about the vulnerability of this community, I think, was so helpful and so important. So just wanted to thank you about that. I also, it was very helpful to sort of that you pointed about the issue with the effectiveness, the extrapolatability of these analyses, the mortality data to other settings. Whether we can say that if a finding was observed in Vancouver, for example, is extrapolatable to the United States. And I guess what my question is kind of making a distinction in efficacy and effectiveness. So I entirely agree with the concern about effectiveness, but I guess I also have a little bit of concern about efficacy, which is to say these analyses, even on the mortality endpoints, I understand it's a large effect estimate, but by comparing one neighborhood to the rest of the city, or the Australian paper was like all of New South Wales to one specific neighborhood in Sydney, there may be other things going on. I would imagine such facilities are established in areas where there is high mortality. So if you make a quasi-experimental comparison, and I don't mean to be judgmental about the papers, this is really the only way to study this kind of thing. You can't do a randomized control trial, but I am concerned about bias on the efficacy estimate as well, which is to say that if these facilities are established in high-risk neighborhoods, for example, there's a regression to the mean issue. There may be other types of interventions. In many cases, the reference group mortality went down as well, strongly suggesting other interventions that may have been society-wide. Again, I do find the evidence persuasive, as it sounds like your team did as well, but really the strength of confidence in the persuasiveness, I guess, is what I'd love your opinion on, especially about this issue of potential bias in these quasi-experimental comparisons around neighborhoods to other types of communities, not only urban neighborhoods, but in some cases rural or small cities, the New South Wales thing.
Can I take the second stab at it, whoever the question was directed at? And
yeah, sure, I would welcome input from anyone.
Okay. Yeah, I get your point, I guess, on, we always call the Vancouver vansplaining, right? Because they're always in there telling us about all the amazing things they do, and Peter calls them the left, or was it the left side, the left coast. But as you heard me mention before, I don't live in Vancouver, and since 2012, I have lost at least 2 to 3 close friends. Not like people I use with once in a while, people I grew up with, people that I worked with, people that were my family. And that's got worse and worse and worse, right? And the reason why we don't have the study and the evidence is because we have such conservative other parts of Canada that it's impossible to open a site, right? Like I had to sell t-shirts to open a site in Atlantic, Canada. I literally sold 500 t-shirts. We sold the bus to get a site open for 4 hours a day, right? So I wouldn't say that I would use it as a counter, right? Like, we know these sites work. Why aren't they everywhere? Why aren't they, why aren't they in every urban city, every suburban city, rural communities? You could look at different ways. We need to look at safe supply. There's no one silver bullet to this overdose crisis, but safe consumption sites are one of the 6 bullets we do have.
Thanks, Jason.
David, do you want to take it first? Yeah.
Sure. So Jason, just to jump in on how ICER thought about this, on the magnitude of benefit, I do think the magnitude of benefit on death from overdose at a CIF, in that, as far as we can tell, no one has died of an overdose at a CIF, is so large that it's fair to have high certainty that people don't die, that reduction is unquestionable. And, we would equally well judge a drug that had, nobody ever died when you took it and there was a substantial rate of death without it as very good evidence for something. I think the Marshall paper has the problems you're talking about. It's worth realizing, though, that although obviously the CIF was in a tight neighborhood, if you look at the actual paper, the further you go out from the CIF, the less the effect is. And the effective area is very small. So, you're still within a neighborhood where there's lots of stuff going on, as far as we could tell. And so you are sort of seeing a dose response, and that's what led us to conclude that we kind of have moderate quality evidence for that kind of reduction in mortality. It's a close call. Whether you agree with that or not, it's hard to argue that you couldn't worry about other biases within the Marshall paper. We did our best to make our judgment about it.
And I would add to that, at the very beginning of this project, as a public health guy, you realize that I'm trying to separate the contextual community factors that are specific to a place from the intervention model itself, right? That's a known problem. We've got a lot of public health experts on the call, and they could probably be more eloquent in describing that than I am. And when we saw the model get replicated, in different places, one of the things that still stood out, right, was the overdose mortality within the CIF kind of held true every time, right? Whether or not it translates into the broader community, that's tricky. And I think we are asking the CEPAC members to say, like, do you believe that evidence? Do you believe that the model is strong enough to translate from one community to another? Or is the downtown east side or other locations that we've talked about in the report so special that the high risk area of Boston, the highest risk area of Boston, is so different that you wouldn't expect similar results? That's
just to piggyback off that. Every site should be unique to their local context, okay? And that's when you bring people who use drugs in, right? Because if you don't, they're not going to be effective. You know, Insight originally had 27 regulations. It was like going into a psychiatric ward to use drugs. But yeah, you have to get on the ground. What are the drugs that are using? What are the main problems, right? And every site should be unique to their local context. So I'm not saying Vancouver would not work in Nova Scotia, right? What we did is we took a little bit from Vancouver, a little bit from Toronto, a little bit from overseas, and we fit it to our local context with, you know, people who use drugs, because they're the ones that are going to be using it every day, right?
Thanks, Matt. I just want to, we're going to have a lot of time to get on these topics during the policy roundtable, and you're raising some excellent points, but we'll have more time then. I just want to get through a couple more questions. Jason Schwartz.
Yes, thanks. Thanks to Dr. Armbrecht and colleagues for all this work. I had a question about naloxone and specifically, I guess, slide 20 that distinguished between the features, the characteristics of an SSP versus an SSP plus CIF. This is not an area I spent a lot of time thinking about, but I was surprised to see naloxone administration not typically, you know, a part of the SSP story, given what we hear about trends more broadly. I wonder if the experts could say a little bit more about that landscape. I'm sure it's heterogeneous. I'm sure it's more than what a table can capture, but given that I suspect that's a big part of the overdose prevention story, how the naloxone work we're seeing, you know, more broadly fits into this and the work that you did.
Yeah, so I would say that an SSP, right, can offer what we might refer to as take-home naloxone, right? So you take it with you. It's then administered, you know, if you're the one overdosing, you can't administer it on yourself, right? So another harm reduction strategy that's in play and it's certainly different today than when the Marshall paper was created, right? That we now have widespread well, I'm not sure we have it, but intervention is widespread distribution of naloxone. So on that chart, when we talk about naloxone administration, it's really that there is a person, or it is available to be delivered whenever needed on an overdose with high assurance that it would be delivered. In an SSP, there may be a take-home option in which a person who uses drugs is given naloxone to be available for them, you know, in the event that they are injecting with another person. An you know, a CIF, one of its key benefits, right, and we heard this loudly from stakeholders, is the death by overdose occurs by people who are injecting alone, right? That's the highest risk attribute, right? It's not the only one, but it's the highest risk one. And in many ways, the ability to administer naloxone is driven by this idea that somebody is not using a drug unsupervised or, you know, without observation. So that's the nuance difference on that table, if that's helpful.
Thanks very much. All right, next question from Steve Kogut.
Thanks. Eric, David, and team, thanks for a great report. I have a question for Eric. If I understand correctly, the Marshall et al. Study measured reduction in overdose mortality, and we might even qualify this as short-term overdose mortality, but we don't have evidence on overall mortality, and this is a population that has many health risks. I've already heard us talking today about mortality reduction without qualifying it as overdose mortality reduction. Can you maybe confirm that I'm thinking about this correctly, or anything else you might add about this issue as we think about net health benefit?
You are. So you are thinking about it correctly. It is, maybe in shortening my words, it is overdose mortality is the focus of the Marshall paper. It's the focus of a CIF. This is a, you know, CIF support a very high risk population from a number of other conditions that can cause mortality. Many of them are their social determinants of health that are in play that I mentioned. So there is no, I would say, there's no evidence that we found to allow us to explore and to talk with confidence around what you might call all-cause mortality. David, do you want to? This was a specific topic that we took a keen interest on at the very beginning of the project.
Yeah. So what you'd like to have, I think, Stephen, from what you're picturing, is if you could know either all the clients of a CIF or all the people who are injecting drugs in a community, you could watch what's happening to their all-cause mortality. Neither of those lists exist. So looking at all-cause mortality in a community when people are dying from all kinds of different things, and it's not like everyone is a person who uses drugs or a person who injects drugs. So you're looking at overdose mortality because that's about the only clue you have that the death you're talking about is in someone who's using drugs. And so that's why that study is kind of most believable. There's at least one modeling study that people quote that has predicted a decrease in mortality and all-cause mortality. We didn't think that the level of evidence there rose to the level of these other things we were looking at, and so we haven't stressed it as much.
Thanks, David. We have time for just one more question before we move on to the evidence and economic modeling. Greg.
Hi, thanks for the report. I wanted to ask, do the SSPs have a very similar radius to the CIFs? And the reason I ask that is I could imagine a policymaker who had one amount of money and would have the question of, do I add an SSP to an underserved portion of my city, or do I upgrade 2 of the SSPs that I have to CIFs? And to know if that's how they're viewing the trade-off, I really want to understand, do the radiuses work the same way?
So in our stakeholder interviews, and I know we've got some other folks that do a lot of work on SSPs that are also on the CEPAC, and so I might ask them to weigh in on this, but our stakeholders would tell us that a service area of an SSP is much larger, right? In part because my willingness to travel maybe once a week or once a month to get my supplies is, that's an easier thing for me to do. It becomes a transactional interaction, right? It probably doesn't have the same sort of trust-based relationship building that people talk about regarding a CIF. So you're right, a CIF has a location matters geographic, a tighter geographic service area, which is why the placement of them in a community matters, right? Like where you put them is going to matter. Probably more so than, I mean, I think an SSP has to be accessible and convenient, but we definitely heard that the geographic footprint or the service area of an SSP location can be much, much larger. Peter, do you want to, I think even Peter has given me some guidance on this topic specifically. So I think you're on mute, Peter. Maybe not. Peter, you're on mute.
You're on mute, Pete.
There you go.
A number of mitigating factors here, rural versus urban. Also, you know, the cost effectiveness. I know you Americans are very interested in, you know, the cost and return on things. To run a proper SIS here, or an authorized one, you require a nurse here in Toronto. This is the, and frankly, I like working with nurses and I'm very familiar with them. I have a medical background myself, but this is a requirement, and a nurse here in Toronto, in Canada, makes $40, $50 an hour. So this is I wouldn't say a burden, but it's an added cost to an SIS. You know, this is I don't know what kind of model you're looking at for your various communities, but to run a harm reduction room to distribute supplies, we do this all the time, and it's also done in more casual satellite settings with community members. They're called satellite sites, and a lot of people won't come into a health center because there's cameras. They're worried about people. They're worried about their identity, and I'm sure, you know, the surveillance that goes on in the U.S. is by far greater than in Canada. And
thank you,
Peter.
Peter.
Why we don't have anybody with lived experience from Boston on this panel.
So thanks very much, Peter. I think that's
one thing.
Matt, go ahead.
they should be this, you know, a safe consumption site should really be an extension of a needle and syringe program, or vice versa, right? We don't have to reinvent the wheel. What are people going into needle syringe programs for? And with their pockets? Drugs. So why are we reinventing the wheel, right? So I think the most cost-effective way to do it is to merge the two.
So thanks for those comments. Those are a great way for us to segue into the economic modeling part of the presentation. So Greg Gazauskas, would you like to transition to your presentation?
Sure. Thanks, Rob. So hello, I'm Greg Gazauskas. I'm a health economist at the Choice Institute at the University of Washington out here in Seattle. My colleague Ryan Hansen. Yeah, say hi, Ryan.
Good afternoon, everyone.
Yep. So Ryan and I produced the health economic model for this topic with assistance from Rick Chapman at ICER, as well as the ICER clinical review team led by Professor Armbrecht, who just spoke. And financial support for this project was provided to the University of Washington by ICER, but otherwise Dr. Hansen and I have no other funding related to this report to disclose. Our objective for this project was to evaluate the incremental costs and cost effectiveness of a supervised injection facility being added to a syringe service program compared to a syringe service program only in various US cities. Next slide. Next slide. All right. Our model's setting is in the United States. So ICER typically uses a healthcare sector perspective, which is focused on direct medical care costs only. But in this case, we aren't dealing with a service that would receive direct healthcare sector funding. And so we took a modified societal perspective this time in recognition that CIFs and SSPs receive private and potentially community-driven funding, and that the outcomes impact the community as a whole rather than just the healthcare sector. ICER models also typically utilize a lifetime time horizon, but in this case, we calculated all of the model outcomes over a single year. So we essentially are comparing 1 year with the CIF versus 1 year without it. Our primary model outcomes were the cost per outcome, including the outcomes of overdose deaths prevented, emergency department visits avoided, ambulance rides avoided, and hospitalizations avoided. Next slide. We looked at 6 US cities as candidates for hypothetical CIFs. Each city's CIF was based on the costs and outcomes of Insight in Vancouver. Since that's the first and it's the most well-documented CIF in North America, those 6 cities were Boston, Philadelphia, San Francisco, Atlanta, Baltimore, and Seattle. And then we have location-specific parameters such as population density, commercial property variables that we use to calculate the cost of mortgage loans, cost of living ratios to compare each city back to Vancouver and inflate the cost of staff, for instance, the number of people who inject drugs within the city's limits, and then the overall number of overdose deaths per year. And for those bottom 2 rows, we found that some cities provided official counts in their public health reports, while in others we had to get estimates from alternative sources such as local news articles, or in one case there was material produced by the field offices of the local Drug Enforcement Administration. Yeah, the field office there. Next slide. So we made several key assumptions in the model, and Dr. Armbrecht discussed some of these evidence issues in his presentation, and I'll just briefly go over them again here. So CIFs in United States cities we're assuming that they're comparable to Insight in Vancouver in terms of effectiveness, services offered, and cost of living adjusted operating costs. And again, that's because that's just our best data point. Insight's the first and most well-documented CIF in North America. Second, we assumed the US cities we modeled have a 1/4-mile radius area somewhere within the city that would have about 2,100 regular clients for that CIF. And that's because the Insight client service rate is again, the basis for the healthcare resource use and for the effectiveness estimates for SIFs that we're using. And we applied that to all of our modeled cities. And so for our results to be correct, we have to assume that there's an Insight comparable quarter-mile radius within the city, somewhere within that US city that we're looking at. Third, we assume that rates of HIV and hepatitis C and other infections are equivalent between the SIF plus SSP and SSP only. And we did this because of the one-year model time horizon and the complexity of estimating the timing of infections and attributing costs to these conditions, since over just 1 year, most people with a new infection may not accrue healthcare costs for that until much later. And also, we just didn't really have a good comparative data set between the two comparators to make this comparison in the model. And then lastly, we assume that rates of initiation and continuation of MAT are equivalent between the two comparators. And this was also due to a lack of comparative data between the two services. Next slide. So overdose mortality prevention that has been discussed a lot already on this Zoom call, and it's one of the most important harm reduction objectives of SIFs. The inputs that you see here are the ones from the Marshall et al. Study, which estimated the overdose mortality rates for the period pre and post Insight within the 500-meter radius of the SIF. And so there's just as a quick side note, we use the imperial system in our report since we're in the US. And so we changed that 500-meter radius to a quarter mile. So Marshall estimated a 35% reduction in fatal overdoses within the quarter mile of the SIF, and then a smaller reduction of 9.3% outside of that radius in the same time frame. So what we did was to take the absolute difference between the within radius estimate and the outside radius estimate to estimate an absolute attributable risk reduction that is conferred by the SIF. And so that absolute difference was 25.7%. And then as with previous studies, we assumed that 5% of each city's overall overdose deaths occurred within the quarter mile radius of the hypothetical SIF. And when we put it all together, the formula for calculating the preventable overdose deaths near the SIF is that 25.7 absolute reduction in deaths times the 5% of people who are using drugs within that quarter mile radius of the SIF in each city times the overall overdose deaths per city each year. Next slide. So for operating and facility cost parameters, we took the Insight annual operating and facility cost and then used cost of living adjustments from Vancouver to calculate these costs for each of our selected cities. This came to approximately $1.7 million for a SIF in the United States. We accounted for facilities costs per year based on factors such as what's the upfront cost based on local real estate, local interest rates, and then a loan duration. We also looked at SSP facility and operation costs, and those were estimated based on a published paper of US-based SSPs, and this reported an average of a variety of SSP settings within the United States. And we used that paper's estimate for a large urban SSP setting. However, we adjusted the budget line items to based on what services were available at the time of the launch at Insight. And so these included things like naloxone distribution, medical testing services, and personnel costs. And that was a way that we could align what was similar between those two settings and then differentiate with the additional services provided by SIFs. And our estimate for an SSP only came to 1.5 million. Next slide. So this table lists variables for our emergency services. And so total annual injections in the SIF were based on Insight, so 180,000 injections per year among 2,100 unique clients, with approximately 1% of total injections resulting in an overdose. Given the number of overdoses, only 0.79% of them resulted in ambulance calls and emergency department visits when they occurred at a CIF, whereas 46% of overdoses that don't occur at a CIF result in a call for an ambulance, and 33% result in emergency department visits. And then given the number of people admitted to the emergency department, nearly half of those go on to be hospitalized. And so we can already start to see where a lot of the cost savings from prevention of emergency savings is going to come from. Next slide. And here are those costs. Each ambulance ride prevented saves approximately $500 depending on the city, and each hospitalization prevented saves between $6,000 and $9,000. We couldn't find city-specific estimates, so we used a common $3,500 per visit for the cost of an overdose-related emergency department visit. Next slide. And next slide. And so here are the results once we put it all together. Adding a CIF results in approximately 7 fewer overdose deaths, 773 fewer ambulance rides, 551 fewer ED visits, and 264 fewer hospitalizations compared to an SSP alone. Next slide. And then looking at the total societal cost for each setting, a CIF plus SSP cost about 1/3 of that of an SSP only. And so yes, a CIF plus SSP does cost more to operate than an SSP only, but then the savings in aggregate emergency services prevented are much greater than the operating cost differences. And so the average net cost savings are approximately $4 million depending on the city. Next slide. We found these results to be pretty robust to variability in our results, or sorry, in our inputs. This is just a one-way sensitivity analysis graph that looks at the impacts of the high and low values for each of our model parameters. And this one is specific to Boston. As you can see, there's like none of the parameters high or low values resulted in a scenario where a CIF plus SSP cost more than an SSP alone. And this held true for each of the cities that we included in the analysis. Next slide. We did a number of scenario analyses in the report, but here's one where we varied the overdose rate down to the threshold at which the cost difference between a CIF plus SSP and SSP alone breaks even. At about a 1% rate of overdose in the base case, the incremental cost of the CIF plus SSP ranges from $3.6 to $4.2 million saved. In the third column are the break-even overdose rates needed for the comparators to be equal cost. And we can see that those rates had to go down pretty low for the break-even point to be met. So we've seen some evidence that if anything, overdose rates may be even higher than the 1% that we used in the base case. So as those rates go up, we could estimate that we'd probably get even more cost savings if it's higher than that. Next slide. So the main limitation of our analysis is that the costs of operating CIF in cities around the US they're extrapolations from a single North American data point. And while the overdose related impacts should be broadly comparable, nonetheless, it's difficult or impossible to capture all of the idiosyncrasies of the different US cities, especially when we compare that to a single Canadian setting. Second, the mortality risk reduction estimates we use also come from the estimated impact of the same single North American CIF at a single point in time. And then lastly, we could not account for rapidly evolving pandemic associated factors, which may have very profound impacts on every aspect of this study. Next slide. So we received some comments on our draft report, and one was that MAT uptake should be higher in a CIF. So we added a scenario analysis in the final report that showed the impacts of increased MAT uptake at the CIF. We also received feedback that risk of chronic and acute infections should be lower at a SIF. And so we added a scenario analysis looking at that as well. And then lastly, some commenters felt that the baseline risk of overdose should be higher or lower depending on the local fentanyl supply. And ultimately we went with a higher estimate than what we had initially planned to use, but the real number for each city is understandably difficult to nail down. But nonetheless, our scenario analysis from two slides back showed that those overdose rates would have to be very low before a break-even cost would be reached. Next slide. So in conclusion, we found that in all 6 cities, SIFs were estimated to reduce mortality by avoiding overdose deaths. The cost of operating a SIF were estimated to be higher than operating an SSP across all 6 cities. However, those costs were offset by cost savings attributed to SIFs through the avoidance of ambulance rides, emergency department visits, and hospitalizations. And then lastly, overall SIFs were found to be cost saving in all 6 American cities, and our results were robust to variability in all of our model inputs. Thank you.
Thanks, Greg. So now we'll take a few questions from the CEPAC panelists. Ed Westrick.
So I'm wondering if you could go back a few slides where you showed the rates of ambulance use, ER use, and hospitalizations.
Just got the, are we pulling up the slides?
Vanta, are you able to? Great, thanks.
Keep going. Right around here. One more.
It should be before results.
I think right before that.
And one more before. There we go.
Oh, there it is. Okay. So I thought it was, first time I looked at this, I thought it was coincidental that the emergency services inputs were the same for ED visits and ambulance rides. And I thought, well, what ambulance ride doesn't end in an ED visit? So that made sense to me. And then I didn't understand why those numbers weren't the same for the SSPs only. Why would there be a differential? Are they saying, no, I don't want to go on this ride. The ambulance comes and they don't follow through?
Stigma.
Right. So, I mean, these estimates were pulled from a previous economic analysis in Baltimore for SIFs. And my recollection is that they had a solid estimate for the ambulance ride parameter. And then they just made an assumption about the ED visits based on the ambulance rides. And that's why those numbers are the same. And so, and we used their estimates in our model.
Okay.
Greg, I think, Greg, the question is, why is it not the same for SSP?
I actually think it has exactly the right assumption about it, which is if you're sick enough to have an ambulance called at a SIF, you're going to end up in the ED is the thought. But some percentage of people who have an ambulance called when they OD out in public refuse the ride to the emergency department.
And that's driven by the stigma and discrimination that they have experienced in traditional healthcare. They try to urge you. I overdosed in July. They try to urge you to go to the hospital. You don't have to. Now, at a SIF or safe consumption site, and Peter may know more, some of the more medicalized ones, you have to go. But yeah, like I would say, you know, the proportion of ED visits resulting in hospitalization, people who use drugs aren't treated very well when they go to the hospital. So you know, I would say these numbers are even like, a lot of times people should go to the hospital and they won't go until they almost lose their leg or they have endocarditis or, you know, like very threatening illnesses.
Thanks, Matt. Any other questions for Greg? Okay, seeing none, I think we can transition to public comments. So thanks very much, Greg, for that presentation. So our